Shall we start, Dinesh, now?
Okay, start. People will come.
Okay, Dr.
Our
Ankit.
IT team is basically
Okay.
just sending message all across that they can rejoin.
Okay. Okay, Dr. Ankit, we can start.
Okay. So we are trying to classify as a major airway obstruction, which means you will have a monophonic wheeze. If on both sides, then it is tracheal. If on one side, it is bronchial. Small airways will have a polyphonic wheeze, which is heard differently on different sides. Now, the commonest would be a foreign body, but you can have endobronchial TB. Dr. Joseph just showed you a case. You can also have vascular links and lymph nodes, and small airway obstruction, bronchiolitis, Walry or episodic wheezing, and asthma. So this is the common differential that we have. You can further have a parenchymal lung disease where you have signs in both phases of respiration. You have marked tachypnea, retractions are prominent. They can be, crepitations, and there can be a grunt. But abnormal control of ventilation is more of metabolic or CNS disorders where you have quiet tachypneas, no retractions, no crackles, wheeze. There would be some alteration in sensorium which will happen, and other systems need to be examined in details. So pneumonias here, you can have conditions like shock, any cause of metabolic acidosis, decay, RTA, raised intracranial pressure, etc. So just to summarize, and then we go on to some cases. In upper airway obstruction, you have more of tachypnea. You have chest indrawings, you have stridor, but no wheeze and no grunt. Lower airways have more of chest indrawings and tachypnea, no stridor, but there would be wheeze and no grunt. Parenchymal diseases have tachypnea, indrawings, no stridor, sometimes can have wheeze, especially with viral problems, and a grunt. Pleural disorders will not have any adventitious sounds, will have reduced air entry, there would be tachypnea and indrawings. So that is how we go about looking at a child. Now, I'll not go into any further details because it is not for an undergraduate or postgraduate teaching. We're all seasoned pediatricians. So I'll just show you a few cases and we can stop whenever the time ends. So just a few interesting cases of respiratory distress. So this is an 8-month-old boy who presented with 3 or 4 days history of fever, cough, and distress, and some reduced air entry on the right side. Now, when you look at this child, then people thought it is possibly a pneumothorax on the right side, some infection, and they put in a chest tube.
Oh.
So I would request everyone to please mute their mics. Requesting everyone to please mute their mics. Thank you. So right-sided, possibly a pneumothorax, possibly secondary to staph. Now a chest tube was put. Now once the chest tube was put, this is something what happened. So you can see a chest tube here, but the right lung has collapsed. Well, why? If you have an effusion on one side, a pneumothorax on one side, then this side the lung should actually expand and fluid should drain. But why is the lung collapsed? So we saw this child. So this happened in the emergency overnight, and when we took the rounds in the morning, we re-examined the child. Distress was persisting, so nothing improved. Rather, it collapsed. Air entry was reduced on the right side, and you have a monophonic wheeze on the right side. So that is something which is unusual for any sort of pneumothorax, pneumothorax, or something like that. So why was the lung collapsed? We don't know. Why is the other lung herniating? So if you look at this, the left lung appears to be herniating on the right side. Why? The ICD hasn't improved things. Why is there a monophonic wheeze? So that is something which tells us that it is possibly not a pleural parenchymal lesion. It is more of an airway disease. And when we took the history again, there was a history that this child was eating corn the previous day. This child was also fed by the older sibling. There was a history of choking and reduced and respiratory distress started after that. We did a bronchoscopy and this is what we found. So there was a piece of makke ka dana which was there and that was taken out. So foreign bodies can present in weird ways and you have to take into account. Now, for example, this child is a 1-year-old, has cough and noisy breathing for a month. Now, this child has no significant fever and has eaten a cucumber. Now, that is something which is very weird. Cucumber is something which is soft and a child can't aspirate that. That's not possible. But this child has got admitted thrice, has got antibiotics and bronchodilators. But as per parent, the noisy breathing persists. So this child doesn't seem to improve. Right now, if the child has not aspirated, then what's going wrong? We have never seen a soft object aspirating. That's very rare. 3 X-rays, all X-rays, you can pass them off as normal, but you can also say that there is some degree of hyperinflation and flattening of diaphragms in all X-rays. So why is that happening? So no fever, no signs of infections, but noisy breathing is still there. Now, again, there's a monophonic wheezing, and that led us to do a bronchoscopy, and I'll show you a small clip. So now as you go inside the trachea, so again, the cords, the glottis, and now you find a foreign body here. So this is actually a piece of peanut. So a weird history. The parents never gave a history of that there's a peanut there. Now, as Dr. Joseph was talking about bronchoscopies, so we do foreign bodies with flexible scopes. It has made things quite easy for us. And I'll show you, we just would pass in a domia in the same sedation under propofol. You do not need general anesthesias. So this is the domia which goes in. This is a tracheal foreign body. You open up the domia, catch the foreign body and comes out, and the child can go home in 2 hours. So you do not need a lot of extensive setup. So this is the domia. You can see the wires of the domia, which are opening up. That can hold the foreign body, and you are out in 2 minutes. So this is the foreign body which is caught, and this is we are taking it out, and you can see how it is done. So foreign bodies you can do with flexibles or rigid. It depends on what technique you want to use and what is the expertise which is available. But there is a distinct advantage of using flexibles if the person who is doing it is confident and has been trained for it. I got trained at Kalavati 7 Children's Hospital with Dr. Virendra, so we have been doing it for the last 10 years or so. These are the instruments which we use for flexible extraction. So these are domia. These are tri-prong things. Domias can be 3 or 4 wire, and different types of things are available, and graspers are also available, which we can do. Even plastic foreign bodies can be done. But there would be cases where we would not do a flexible but do a rigid, because rigid has some advantages, although it requires OT anesthesia and the cost triples. But definitely there's a distinct advantage of doing a rigid in a few situations. So the situations are few and far, but they're there. So for example, this is a 1-year-old girl who came to us, I think a year or 2 back. There was some history of eating peanuts in the end of December, remained well. Some weird history, remained well. In the first week of February, this child was got admitted. People thought it is a laryngotracheal bronchitis. This child did not settle completely, but improved. Now again seen in February, and the stridor is still there. Stridor now increased with a viral infection. So somewhere in the end of March, this child got admitted with us. So the history is December. This child has remained somewhere well in between, but there is some stridor which is going on. So it's a bit weird which is happening. So inspiratory stridor, some weak cry, you're thinking in terms of laryngeal. Now, laryngeal foreign bodies, you can't hold on with your flexible scopes. You need rigids. So we went ahead to the OT and to see what's going on. When we did a bronchoscopy, you see a beautiful subglottic foreign body, which is lying here. So this is a subglottic foreign body, which you can see in between the 2 cords, which is there. Now this child, so we had to extract this foreign body with a rigid bronchoscope. Now once we did that, the anesthetist could not extubate this child. And you were that, why is that happening? Why is this child not improving? So they asked us to do a flexible again. And because in the rigid, nothing else was there. Now, when we did the flexible, and as I was coming out, so this is when I was coming out towards the glottis, and this is what happens. There were large granulation tissues which were formed around the foreign body. That was the problem which was associated. This is the reason why the child could not be ventilated easily, and they required to intubate this child. So this child was taken to PICU, remained on the vent for 2 days. We gave steroids, repeated a bronchoscopy, everything remained well, and the child was discharged. So you need both flexible and rigid sometimes to do complex foreign bodies. So let's look at one or two more cases, and then we'll try and end. So this is a child, and the birth history is there. So a cesarean section was done for a non-progressive labor that guards was normal. But this child developed respiratory distress at birth, required a CPAP. There was some bradycardia apnea in the nursery, and the major concerns was axial hypertonia. So this child was planned for karyotyping and genetic opinion, but at that time the parents weren't very keen on that, so they went home. But there was some problem of hypertonia. Now this child was seen again at 2 years of age when this child got a viral infections, had a cough, cold, coryza, and difficulty in breathing. But the lethargy was out of proportion. The tachycardia was there, but there was no significant tachypnea. Because of poor sensorium and lethargy, this child was referred as suspicious pneumonia to us. Now, the tachypnea wasn't there, and we had in the back of the mind that yes, this child had some hypertonia. So this child was appearing more sick than what we expect this child to look at. So this child was taken to ICU, had to be put on BiPAPs. The ABG, so the ABG, if you look at this ABG, the CO2s are sky high. The CO2s are 90. Why? And the PO2s are still well maintained. Why? So we weren't sure what's going on. We reviewed this child as a weak cry, this child as an ineffective cough. So this child actually was in type 2 respiratory failure, secondary to viral infection, and had an underlying neuromuscular disorder, which actually got precipitated with a viral infection. So this child was managed well and then went home and still under follow-up on a nighttime BiPAP and remains well in between. So it is a type of a congenital myopathy, but these sorts of respiratory failures can also present you in clinical practice. So we have to be careful about neuromuscle because especially young children, they may not show you typical signs of respiratory distress because of profound weakness. The tachypnea and retractions can be seen, but the absence of tachypnea or retraction does not rule out a respiratory distress or a failure because it is not like a type 1 failure. They have more of type 2 failures. Look for a weak cry, ineffective cough, choking with feeds or secretions. Look for weight loss or a poor weight gain. So these things are important. Look at repeated chest infections and paradoxical breathing. So these are the signs which anyone should elicit in a child who is known or suspected to have neuromuscular disorder, because the classical manifestations of the respiratory failure, which we have talked about, does not hold true in this group of complicated patients, and sometimes it is actually missed.
Dr. Ankit, we have 2-3 minutes more.
Yeah, so I'll try and end. So this is a 7 years old, and I think this is the last case. 7 years old boy who has been a snorer for 2 or 3 years. Loud snoring, persistent, some intermittent gasps, no clear apnea. So the current weight is 92 kgs. So for the past 3 days or 5 days, he has got some increased difficulty in breathing, no cough. Now this child was admitted in some hospital, was dyspneic, hypoxic, and managed as asthma. There was some wheeze in the chest, but there was no clear improvement after being managed. So this is the reason why the child was referred. Now, again, when we saw this child as a very high BMI, well, we do understand this child as obesity, but what's happening to the chest? So the heart rates, respiratory rates were high. There was a large liver. That is something which is unusual. So only occasional wheeze in the chest. Again, the PCO2 shows 81 mmHg, and echo shows severe pulmonary artery hypertension. So what's going on actually? So this child had a cardiomegaly, and this child actually has an obstructive sleep apnea with pulmonary hypertension and a cor pulmonale. So got supportive treatment, was started on auto CPAP, required sildenafil, furosemide, gradually weaned off oxygen. The sleep study we did for titration of pressures, the AHI improved. Later was followed up at endocrinology and combined respiratory. Endocrinology has ruled out all causes of obesity. They could not find any secondary cause and awaits a bariatric surgery. So I think I'll leave the last case. This is a child who had sudden respiratory distress. We weren't sure what's going on, and later it was found to be a laryngeal TB. We were thinking in terms of upper airway obstruction, but had this sort of an X-ray. The mother was on ATT, and when we did a bronchoscopy, we find that it was a laryngeal involvement with tuberculosis. So just to sum up here, and a child with respiratory distress, do your initial assessment, a triangle or a pentagon, which we want to use, and try and make a syndromic diagnosis. And depending on that, you can further classify them as upper airway, lower airway, or pneumonias, or parenchymal diseases, or cardiac CNS, or metabolic disorders, and try and go on to a specific set of investigations if they are needed and decide further. So stepwise evaluation is something which is needed for evaluation of a child with respiratory emergencies. A syndromic assessment or approach is important for classification and initiation of treatment. And then you can do a focused set of investigations to make a further diagnosis. So thank you very much. And if there are any questions, then and if we have time, we can take them up.
Thank you, Dr. Ankit. I request our chairpersons, Dr. Anurag Agarwal and Dr. Ajay Gupta, to give their comments, and then we can take two questions.
Yeah, sure. Thank you, Dr. Manish. Congratulations, Dr. Ankit. It was a nice presentation. But as they say, prevention is always the best. Most of the cases of respiratory emergencies are related to foreign bodies. We must tell all the parents, whenever they visit us, to take precautions. Thank you. Dr. Anurag, please.
Nothing much to comment. Presentation as usual. And the algorithm on diagnosis of respiratory, in fact, any respiratory disorder or a respiratory emergency is something which all of us need to know and learn. The reason is a lot of the times our residents are missing respiratory distress till it's a bit late. So counting of respiratory rate, looking for retractions, looking for grunting, looking for indrawing, and then looking for SpO2s and capillary filling time. So that will tell you where is the child heading to. A simple sign, looking at anxiety on the face of a child. Anxiety, if it is visible on the face of a child, that means the child is going downhill and is going into respiratory failure. So type 1, type 2 respiratory failure. All these are very important clinical concepts which do help a clinician in making a diagnosis before moving towards all kinds of investigations. Other than that, I think bronchoscopy is definitely an important tool, and indications of bronchoscopy should be known to all of us. And besides that, I think there is a question from a participant. He has a very simple question. How do you differentiate between Walry and bronchiolitis? Dr. Ankit can answer that.
I think bronchiolitis is typically defined as a child between 2 months and 2 years of age develops a viral infection, which means some cough and coryza, and followed by respiratory distress. There may or may not be a wheeze. So that is a typical definition of bronchiolitis. And if you look at data, then it is said that 95% of children who present with this clinical syndrome will be a bronchiolitis only, and the possibility of this being any other thing is quite low. Walry or episodic viral wheezing or hyperreactive airway disease is a term which is used in general for an under 5 child who gets repeated episodes of wheeze, where it is thought that it is the reaction to the airways is more because the airways are possibly hyperreactive. So usually you don't use the term for the first episode, but for repeated episodes.
Okay, I think that is a pretty good answer. So standard teaching is a happy child with fast breathing who points towards bronchiolitis. Yes, child around 2 months of age has some amount of tachypnea, which seems to be a bronchiolitis. And realize the child is very much settled, points more towards Walry. So these are minor differentiations which are more of academic in nature. Clinically, the treatment remains mostly the same. Both have viral etiologies, so management is grossly the same. And of course, multiple wheezing episodes with recurrent viral infections, then you go towards
thank you, Dr. Anurag. I think now we'll move on to next session. Thank you, Dr. Ankit, Dr. Ajay, Dr. Anurag, for a good discussion on pediatric respiratory emergencies. Thank you very much. Now,
okay,
to Dr. Hema to take us to the next and the last session of the day. Dr. Hema, please.
Thank you, sir. For the last session, it is a very interesting talk about cough syrups, point of debate. So we all know that we all have this tendency of writing cough syrups to use acetylene, dextromethorphan, aminophylline, doxyphylline. So we have actually we have a bad cough syrups key. So now we have Dr. Vineet Sehgal who will tell us about these cough syrups, that which are the ones to be used, which are the recommended, and what not to be used. So I invite speaker Dr. Vineet Sehgal for this talk. Dr. Vineet Sehgal needs no introduction. He is the Delhi PRS president, and he is a consultant at Max Shalimar Bagh, and he has also been the National Respiratory Chapter president in 2015 and 2016. Sir is a well-known trainer for a lot of IIB modules on respiratory and other modules also. To chair the session, I would invite Dr. Girish and Dr. MP Singh. Um, is Harsh there? So Dr. NP Singh is a consultant at Dwarka, and Dr. Girish is also a well-known consultant, has been the ex-president at IMA Panipat. So I invite and hand over the talk to Dr. Vineet Sehgal, sir, please.
I'm unable to share my screen. I think it says your screen has been disabled, screen sharing.
Now you can do, sir.
Dinesh?
So
You
now
can
the
do, sir,
talk is
now.
there with you, sir.
Vineet, now you can do.
Okay, let me see. Is my screen visible now?
Yes, sir.
Yes, it seems, but it is all blank.
Coming up right now? Not showing up?
No,
So it is a blank slide which is coming.
Blank slide. Can you move it further? One slide further.
Is paused. Says your. Okay, just let me see. Now.
You can
No,
see
sir.
your computer screen, but it is all blank. Your cursor is moving.
Says your.
What does it say, Vineet?
Says you are screen sharing, but then. Now can you see the screen? Your screen
is all blank. Can you see the screen slide on your computer? You are seeing the slide in your computer, but we are seeing only blank screen.
Your screen sharing is paused. Screen
Paused.
sharing is paused. Zoom share. Now is it showing?
No, sir.
Now is it showing?
No. Harsh?
Wonders of technology. Let me close it all over again and then open it.
5% error is permitted, boss. Dinesh? Harsh?
Maybe I'm sure the error must be from my side.
No. It is actually.
Sir is already a co-host, so he can share.
But Dinesh, now it is there. Vineet, now we can.
Is it okay now?
Yes.
Yeah. Now it is clearly visible. Go ahead.
Sorry for the delay and glitch, but towards the end of the day, from the high-tech and excitement of respiratory emergencies, bronchoscopies, non-infective pneumonia, we are. I'm sure most of us can relate to this more than the bronchoscopies and the tough pneumonias that we were talking about. Because when you have cough syrups, this is what your clinic looks like. It's a busy clinic. You make lots of money. You take away the cough syrups, and this is what your clinic is going to look like. Not just in COVID times, but even normal times. If you don't prescribe cough syrups, this is what the clinic is going to look like. So that is the importance of cough syrups for us general practitioners. Whenever you go to any of these conferences, the bottom line usually you get is that there is no need or no indication for cough syrup or cough suppressants in acute cough in children or URI. But I'm sure there is more to it than that. There is economics versus the science. There is experience versus the lack of evidence. And of course, there is always a conflict between rationality and irrationality. So let's kind of first try to tackle the irrationality. So there was this study published in 2013 which talked about all fixed drug prescriptions, and this is from India, and it said that of all FDC prescriptions which are written in India, only 5% are rational. So that's the figure. 95% are irrational, and almost 3/4 of the FDCs are either pharmacologically incompatible, or their pharmacokinetics parameters don't match, or their ingredients interact with each other. So that's the extent of irrationality in the FDCs which flood the Indian market. But is the private practitioner or the general pediatrician really to blame? So let's kind of take two indicative mixtures which are commonly available. I won't call them cough syrups because they are more like cough mixtures. So one common combination you have dextromethorphan plus chlorpheniramine plus phenylephrine, which the drug authorities ban. But every second cough syrup which is promoted to you is this combination. So if it's really banned, then why are they manufactured, or why are they allowed to be manufactured, and why are they promoted to the practitioner? If they're in the market, then they are going to be used. On the other hand, you have another combination, again very common, terbutaline with ambroxol and guaifenesin, which the drug controller lists as an approved combination, which begs the question that is it really a rational combination? You have a bronchodilator, you have a mucolytic, and you have an expectorant, when children less than 5-6 years of age can hardly expectorate. So why sanction such a combination, which really doesn't make sense? So like the top of the slide says, that is the practitioner really to blame? Because if he's flooded with all these things, he's going to write them sooner or later. So that's the irrationality we are talking about. And to compound that irrationality, these cough syrups have multiple toppings like ammonium chloride, sodium citrate, bromhexine, pseudoephedrine, triprolidine, cetirizine, levocetirizine, montelukast, and of course, not to miss, you also get a little bit of paracetamol added in that. So when you have so many ingredients in a cough syrup, how do you really make sense of it? And you don't get single ingredient or two ingredient cough syrup. So you have to, by force write these cough mixtures, so to say. So that's the level of irrationality we are, dealing with. But let's try to get more rational. So for cough syrups, we basically answer three questions in this talk going on. That one, are cough syrups needed? Two, are they effective? And three, are they safe? If we can answer these questions, I'm sure we can reach a rational decision as to use of cough syrups. So coughs basically are defined by their duration. So you commonly label an acute cough as a cough of less than 3 weeks duration. Some authorities might say 4 weeks, but commonly 3 weeks is the accepted definition. 3 to 8 weeks duration is subacute, and more than 8 weeks is a chronic cough. The chronic cough is a separate topic altogether, and we are not touching on it because that usually involves some organic cause which needs detailed investigation, and you need to treat the underlying cause rather than the cough. The acute coughs, vast majority, I would say more than 90% in children, would be viral URI related. Or if they are slightly prolonged, they are what we call a post-viral cough, occasionally pertussis. Asthma, sometimes yes, but then asthma obviously needs a definitive treatment, a bronchodilator. So we will not talk about it. We will limit ourselves to an acute cough, which is usually viral URI related. The classical teaching and well accepted is that yes, cough due to URI is usually transient and self-limited. But transient, 3 weeks, 4 weeks, for the parents, it's hardly transient because the cough gets bothersome and disrupts the life of the patient and his parents. The quality of life suffers, the child is unable to sleep, they keep coughing and they have post-tussive vomiting, they miss school. So though for us, the cough might be transient and self-limiting, but it's quite a bother for the parents. And that is where the need for the cough syrup is. And there was this publication in the British Journal of Pharmacology, a recent one, I think this was 2015 or 16, that therapeutic options for cough suppression are extremely limited. However, a significant need exists for safe, effective antitussive medications which suppress the acute cough without any undesirable side effect. So that is as far as the need for a cough syrup goes. We do need a cough syrup which is effective and safe. As far as efficacy of cough syrups goes, it's kind of difficult to demonstrate efficacy of cough syrups for the simple reason, or rather there are three reasons which are given. That one, the cough associated with the URI is typically transient and self-limiting. So you really don't know when you are trying out a drug that has just the infection died out, has the pathology died out, or is the antitussive agent effective. Two, there is a huge element of a placebo effect observed in most antitussive or cough syrups, because they are usually in syrup forms. There is a demulcent effect, there is excipients which give some flavor, some warmth, some cooling agents. So all these add to the placebo effect of cough syrups. So to kind of tease out what is the effect of the active ingredient from the other excipients is difficult. And then how to subjectively, or rather objectively, how to objectively, define or measure cough. So there is lack of well-validated, commercially available, instruments for objective cough counting. So all these three parameters or reasons kind of make it difficult to really objectively assess the efficacy of a cough syrup. So that is where, your subjective parameters come in. So what's the take on the efficacy of cough syrups? This was by one of our co-faculties, Dr. Joseph, who was with us just about an hour back. This was a publication done in 2009, I think. And it said that cough syrups are no better than placebo in children for acute cough and have the risk of side effects. Therefore, their use should be discouraged. In a slightly more recent publication, 2014, which was a Cochrane review database, it said that they reviewed the RCTs that were available, the meta-analysis that were available, and they said that the antitussives, antihistamines, antihistamine plus decongestants, and antitussive bronchodilators were no more effective than placebo. However, they also went on to say that 2 pediatric cough syrups showed a satisfactory response of 46 and 56% compared to 21% in the placebo group. And then they also said that 3 types of honey were more effective than placebo. So that rather than, sorting out your confusion adds to the confusion of the practitioner. Cough syrup, should I give or not give? What does Cochrane say? Are they effective or not effective? A further study or a further publication, this was in 2016. This was on the European antitussives. And this was again a comprehensive evidence-based review. They said URIs are benign and self-limiting. Patients with milder symptoms should be just reassured. The demulcent effect of honey and lemon may bring about a significant improvement in symptoms, though it might be just of a short duration. And this should be your initial strategy in children. They also went on to say that in isolated dry or minimally productive cough, dextromethorphan has the best evidence base. And the adult dose that they said was about 30 milligram per day. And they also said a cough persisting longer than 2 weeks should be evaluated, though most authorities take it as 3 weeks. So they promoted honey and lemon and dextromethorphan as effective or more effective than placebo at least. So I'll just take up 2 or 3 of these compounds, antitussives, which are commonly available to us. Dextromethorphan has the most largest database or evidence base, I would say. And the most studies which have objectively evaluated cough counts, etc., have been on dextromethorphan. The problem again, like I've mentioned, is that you can't eliminate the placebo effect or the demulcent effect of the syrup. So how much alone dextromethorphan is effective. It is estimated that if you kind of account for all these things, spontaneous remission, placebo effect, demulcent effect of syrups, then still the dextromethorphan has a plus 17% antitussive effect. But it is important to remember that in children less than 2 years of age, dextromethorphan should not be administered. So if you are using a dextromethorphan-based syrup, avoid it in children less than 2 years of age. Then the other 2 newer antitussives that are available to us are levodopa and levocloparastine. And these were developed to avoid the central effects of the other opiate, non-opiate antitussives that we had before these. And these have been here in our domain since about the early 2000s. So levodopa is a non-opioid antitussive which has a primarily peripheral mechanism of action, while levocloparastine has both a central action and a peripheral action. So the proponents of these two compounds, antitussive agents, have their own take on it. And levodopa is a compound which was studied or has been used more in Italy and thereabouts. And the studies, most of the meta-analysis and studies are from there. But now it is accepted as an effective antitussive agent. And it is said to be more effective than the centrally acting antitussive agents such as codeine, chlorperazine, dextromethorphan, both in terms of reducing the cough intensity and frequency and nocturnal awakenings. It is available to us, though there are side effects of nausea, vomiting, heartburn, etc., and they might interact with other sedatives. And a little bit of sedation is reported with this also, even though it's a peripherally acting drug. Levocloperazine, its proponents say that this is probably a more effective antitussive than levodopa. Again, it is available to us and it is an option in children also. And their studies show that the levocloperazine seems to work better than levodopa. So different groups have different takes, and it really doesn't solve our confusion as to which agent is safer or which agent is better. But yes, both these are probably better than the centrally acting antitussives. Adverse events with levocloperazine are reported to be minor and transient, and they say there is no evidence of central side effects such as sedation and drowsiness. So that's where your efficacy goes. So the best evidence base is for dextromethorphan, but the other two drugs which might be useful are the newer ones, that is the levodopa and levocloperazine. As far as the third question goes of safety, all of you have been told and taught and have learned that there are multiple side effects possible with cough syrups. And potentially and commonly reported adverse effects, they are protein, and you can see them listed here: tachycardia, very commonly somnolence, lethargy, hallucinations, agitation, irritability, constipation, tremor, hyperactivity, etc., etc. This is all what is reported in literature. But what really is the safety profile? So there was this huge surveillance study done in the US, which went on for almost 6 to 7 years. And surprisingly, what they came out was that the overall rate of adverse effects was equivalent to just 1 in about 1.7 million units sold. So adverse effects or adverse events were just 1 out of 1.75 million units sold, a combination of tablets, capsules, or liquids. So not a particularly high adverse effect rate. And the majority of the adverse effects, they occurred in children less than 4 years of age. And almost 60% of them were due to what they called AUIs, accidental unsupervised ingestion. So when the baby opens up the bottle by himself and gulps down a huge quantity, more than the prescribed dose. And of course, another 13% was medication errors when the caregiver did not follow or did not understand the prescribing prescription or the prescribing information, and again gave an overdose. So what they concluded was that fatalities were rare and occurred mostly in children or less than 4 or 5 years of age, and none were determined to have involved when a therapeutic dose was given. So this is kind of reassuring that if you prescribe a proper therapeutic dose and the caregiver gives the proper therapeutic dose and there is no accidental ingestion or extra dose of the cough syrup, it tends to be safe. So this is as far as the safety goes. So not as unsafe as it has usually been, taught to us or pushed to us. Now, just a little bit on the honey, because honey is something which is now coming into the Western world, but our ancestors, our earlier generations have been using this as a cough syrup, a mixture of, just honey with warm water or honey with ginger, with black pepper, etc., etc. And it seems to work. It worked for my grandmother, it worked for my mother, and it worked for me, for my children. And even Cochrane seems to accept that it probably relieves symptoms to a greater extent than diphenhydramine or placebo, however, not probably as effective as dextromethorphan. There is no difference in the adverse effects between honey and its comparators, but it is not recommended for children less than 1 year of age because there is this risk of infant botulism. So that is what I wanted to cover: the need, the efficacy, and the safety. And briefly, in one slide, I would like to put across the take-home messages for cough syrups. Remember, cough is an essential defense mechanism. So you don't unnecessarily, suppress the cough. But however, if it is excessive or persistent, then yes, it does need a little bit of amelioration. We have very limited antitussive options, agents available to us. We are an effective, well-tolerated and safe agent. It is difficult to demonstrate the efficacy in URI because of the self-limiting nature of the illness and the large placebo effect of the cough syrups. Remember to avoid cough mixtures which have multiple active ingredients. So you don't need a dextromethorphan and phenylephrine and a CPM and maybe an ambroxol with it and paracetamol to top it all. Go for a cough syrup which has just one or two, maximum two agents, active ingredients, which you can track and know. And know your cough syrups. Adverse effects are rare in therapeutic doses. And dextromethorphan, levocloperazine, and levodroperazine seem to be the most appropriate antitussives available to us for acute viral coughs at the present moment. Of course, science keeps evolving and new developments happen. So maybe we'll have a newer and a better antitussive. That is it for me. Thank you. And I'm open to questions. Sorry to rush through it because I was conscious that we are already overshooting and I just wanted people to listen to me rather than switch off. Sorry. Open to questions.
Thank you, Dr. Vineet. I am Dr. N.P. Singh for the topic of the need of day-to-day practice. Actually, we all are prescribing, and almost every prescription now season is coming will have one or more this such type of products. I must thank you that you are giving leverage to use this dextromethorphan in 2 years and above, but rightly in consensus decision is that the cough syrup should be used after 6 years of age. That is a global consensus, and also that long-acting dextromethorphan or any other long-acting substance is usually indicated after 12 years. So it is very, very, very reassuring that at least 2 years above we can use safely, because without that we pediatrician will not survive. That's true.
I showed you the clinic, how it will look without cough syrup.
Yes, sir, surely. So few points I just want to add in our day-to-day clinical practice, that one must remember that these products do not cure or shorten the length of common cold and may cause serious side effect. And one important thing that do not use this product to make the child sleepy. What happens paradoxically that if you use in the smaller infant, they usually cause agitation and excitement rather than promoting the sleep. Secondly, always check the ingredients on the label, even you have used the product before, because what happens that manufacturer may have changed the ingredient without any giving publicity or any notice. And also product with the similar brand name may contain different ingredient that mean for the different purpose, and we usually make some error in prescribing the multiple drugs in a single prescription. We are encountering that if somebody is referred by some other colleagues, then we have 2-3 cup syrup and combination of all the things, antitussive, antihistaminic, bronchodilator, as you have explained everything. So sometimes one or more component may have additional cumulative effect by combining the two more or less similar cough syrup and leading into trouble. So, and obviously other side effect, usually constipation is seen if you use prolonged cough syrup therapy. Thank you.
Yes. The changing of compositions without information and similar sounding syrups, yes. You might think कि उसके जैसा ही होगा, but it's radical. Any questions you might hear out there?
So few questions are there in the question answer section. That the dose of phenylephrine is around 5 mg in most of the syrups. Does that cause severe hypertension?
Phenyl, actually, like I mentioned in my talk, really, because if you're just looking at an antitussive, phenylephrine, usually pseudoephedrine is already out. Phenylephrine also you would avoid because you run into more of side effects rather than effects. So I would avoid a cough syrup which has phenylephrine. And again, as NP Singh mentioned, might have 5 milligram one day and the next day they suddenly bump it up to 12.5. So I would avoid, I would probably look at a cough syrup which just has dextromethorphan or levodroperazine or levocloperazine. I know these are difficult to find, but the maximum you could do is a dextromethorphan and a CPM compound beyond that really.
I actually want to add one point about the phenylephrine, because phenylephrine usually used as a decongestant. So if you want to decongestant, use as a topically. Sometimes in the smaller strength, lower strength, topical and decongestant is better. But using decongestant as a oral route will not help. It will end up into more trouble. That is true.
So there's another question in the chat box. I think you've answered it already. That levosalbutamol containing syrup for bronchodilator, along with ambroxol for mucolytic action, to use or not to use. I think it is.
That I had already mentioned. In smaller children, you don't want them because they can't expectorate. You are thinning out their mucus and you are run into problems. And I think there was another question on use of codeine. Codeine, by and large, now is discouraged, and frankly, I doubt now if we get any codeine preparation in India. So, because the central nervous effects and the constipation effects far outweigh, and the abuse potential of codeine, whole codeine, noscapine is there. So, they are best avoided. And I doubt if we get anything in the Indian market now. Maybe one or two preparations I'm not aware of.
Thank you, sir, for making us more wiser to use cough syrups or not to use and what to use. I mean, this sea of cough syrups which are available in the market.
Use them judiciously, use them sensibly. You have to use them. Thank you.
So I request Dr. Dinesh Mittal for closing of the sessions for the day of the conference.
Thank you, Dr. Vineet sir, and thank you everyone for such an informative session. Today's session was a bit long. It lasted almost around 4 hours, but tomorrow we'll be having not that long. We'll be having 3 hours session. But today's session was very informative also, and I am very hopeful that everyone would have been benefited by it. Tomorrow also we have very interesting sessions and a live training on ultrasound by Dr. Dhiren Gupta. And I'm really sorry for a technical glitches that was absolutely beyond our control, because that was from a Zoom side, and our technical team but revived it in a no time. So thank you very much for today's, and we'll be meeting tomorrow at 2:30 p.m. sharp. Anything, Dr. Shalini, you want to say?
No, Dr. Dinesh, thank you very much, everyone. I think we should conclude this meeting right now. Thank you, everyone.
Dr. Manish, final comments?
Thank you, everyone. I think barring few glitches, this was excellent. Dinesh, Hema, Shalini, and it was excellent, highly informative contents, and we look forward to 2 more days of full scientific content. Thank you, everyone.
Thank you, sir.
Tomorrow.
Good luck.